I am a director of clinical services for one of California's 21 regional centers. There is a system of 21 regional centers that coordinate care for individuals with intellectual and developmental disabilities who are community dwelling. And the National Task Group on Intellectual Disabilities and Dementia Practices is actually an international organization that is dedicated to this group of individuals who are aging with cognitive decline. And I'm hoping that on the basis of today's presentation, you may even be interested in joining us in that group. We welcome people from all backgrounds and disciplines who share that interest with us. So again, we want to give acknowledgement to the Administration for Community Living and the Catholic Charities for their assistance, and of course, University of Hawaii. So thank you very much for enabling this presentation. So we have a lot to accomplish today, and so just to kind of give you a roadmap for where we'd like to go within the next hour and 45 minutes or so, is that we want to consider research, best practice, and policies that guide us in establishing healthy habits for brain health as individuals age with disabilities. And what do we know about the trajectory of healthy brain aging for persons with IDD, intellectual and developmental disabilities? And what are some of the considerations about aging with a disability and with dementia, including a review of the National Task Group Early Detection Screen for Dementia? So you are going to get a very brief overview of that tool, which we think can be very helpful to family and professional caregivers in capturing observations of change as individuals age with intellectual and developmental disabilities. So what do we know from the World Health Organization in terms of they came out with a Promoting Health Through the Life course last year. And it's across the life course, people can improve their own health and well-being by learning about their health and well-being and making informed choices. So a lot of what healthy aging is about, and I will promote this in my talk this morning, is about the choices we make. We can make a very big difference in how all of us age in terms of cognitively and just in terms of well-being. It has to do with choices such as, are we physically active? Do we limit the amount of tobacco and alcohol that we consume? Do we follow improved nutrition? And do we manage our stress on a regular basis? And so this is something that has been recognized as the World Health Organization as a possibility in promoting healthy brain. It's part of the Healthy Brain Initiative that we are undertaking throughout this country. So the good news is, although we don't have a cure for aging-related cognitive decline, there's a great deal we can do to reduce the risk of that decline. Many health conditions and lifestyle choices put us at risk for poor health and cognitive and functional decline as we age, but they're modifiable. So that is the good news. We can do something about it. And healthy aging means healthy brain aging. It is the same thing. It is also the same thing for people with disabilities as it is for people without disabilities. The basic principles of healthy aging are the same for all of us. So as you're sitting here and listening to me, I'm hoping you're thinking about what you're going to be working on. I know that I'm thinking about what I'm going to be working on in terms of aging in a healthy manner. So it's interesting because my original training in psychology was as a gerontologist. And one of the things that we used to say is Aging is a lifelong process. And you may think, well, gerontology has to do with just the study of older adults. But in fact, it is very important to know about the childhood, early adulthood, and later adulthood of the individual if we're looking at how people age. So we're very influenced by things that have happened to us in childhood, early and middle adulthood. We want to begin healthy lifestyle choices as soon as possible. It is never too late to start engaging in healthy habits, and it's never too early to begin that process. And we want to follow regular and routine health care. In fact, people whom we work with who have intellectual and developmental disabilities have more likely have medical conditions that co-occur with their disabilities. And we want to be particularly clear that we're getting the kind of health care and routine follow-up that they need. So I want to put attention to exercise, nutrition, how we manage our stress, our relationships, and pursuing meaningful activity. And we also want to put attention to chronic medical conditions, which will impact the overall health of us as we age, whether we have disabilities or not. So factors that can affect brain health. Well, one of the things that is not modifiable, at least at this point in time, is your genetic makeup. You do inherit certain tendencies in terms of your overall aging. You probably have, relatives that have lived to a certain age, and that puts a certain parameter or boundary on how long you can expect that these tendencies are in families. And there's certain medicines, there is smoking or excessive alcohol intake that are known to be risk factors in terms of reducing healthy aging. Diabetes and heart disease. And the truism is a healthy heart is a healthy older age. So absolutely anything like diabetes or heart disease will put you at higher risk for a number of other complications that will compromise your aging. Depression, which we will have more to say later on in the presentation, that is also a factor that limits you. It affects quality of life, but it also appears to affect your immune system and the degree to which you might be more susceptible to certain health problems. Brain injury. We know as people age, they may be more susceptible to falls. And we have to be very concerned about individuals with whom we work who already have may have some compromises, additionally acquiring brain injury as a result of accidents, or falls. So poor diet, insufficient sleep, lack of physical activity, and lack of social and mental stimulation are all factors that we know affect brain health. Right? So we're going to take a little closer look at all of these as we proceed through the presentation. So the two main categories that we're going to look at today in which we can modify our risk for some of the problems of aging and healthy cognitive aging is in looking at treating comorbidities. In other words, any illness or chronic medical condition needs to be treated as part of health maintenance, and that will have a lot to do with our overall brain health. And of course, lifestyle choices. There are a lot of things that I've alluded to and will continue to talk about that have to do with the choices we make on a daily basis that will influence the trajectory of our own brain health and that of the people with whom we work. So what's interesting is when I started in the field of working in disabilities, it was a relatively rare event to see somebody live into their 70s or 80s. Now it's fairly more, I wouldn't say it's necessarily commonplace, but it's certainly not uncommon to see individuals with various disabilities, intellectual and developmental disabilities, live into their 70s or 80s. In the regional center, for which I'm the clinical director, the youngest person that we serve is only a few months old, because California is the only state in the country that actually mandates disability services beginning, for children as well as for, adults. And then the oldest person, I think at this point in time, is 86 that we are supporting in the community. And there's several people in their early 80s. So that improvement in lifespan, not long ago, it was very rare for somebody to live past the age of 35. Now we have improved access to and treatment of associated physical conditions, heart defects, seizure disorders, use of antibiotics to limit recurrent infections, and the development of a proactive and holistic individual care philosophy within community settings, and a decline of large-scale institutionalized generic care. In other words, to the extent that we can individualize the care for people and not provide institutional generic care, we are more likely to be able to support a longer life and health of the individual. And of course, encouragement and support that provides the opportunity for people to age in place within their own homes and within their family homes. And that is a relatively new occurrence within the field of disabilities, and one that has a direct impact on longevity and healthy aging. So it's exciting, okay? Well, and older people with intellectual and developmental disabilities have the same needs as other people. Right? So again, we're basically trying to destigmatize this and just look at the fact that the same principles that govern health and aging are going to apply to people with intellectual and developmental disabilities. The increasing life expectancy of people with intellectual disability is now an established fact. Just as we are looking at the aging tsunami in the general population, we are looking at that happening within our population of individuals with intellectual and developmental disabilities. And of course, older people with intellectual disabilities are subject to compound stigmatization for being both older and having disabilities. So that's something that we need to be aware of as those people who are involved and trusted in supporting these individuals. So again, many adults with intellectual and other developmental disabilities can now remain at home and enjoy family living. And we know the support of the family system is essential in health. We are meant to live in families. Yeah? So there are certainly changes that are going to happen as we all age. And it's really important for us to consider what some of those changes might be. And I've just summarized a few of them. This is not all the entire list of changes that might occur. But we do, all of us, experience age-related bone loss. We may experience progressive loss of muscle mass. Okay? And this has nothing to do with whether you have disabilities or you don't have disabilities. This is just one of the things that happens as we all age. The lens of the eye becomes stiffer and less flexible, affecting your ability to focus on close objects. I certainly have experienced that. It makes it harder for us to visually accommodate even if we may have had 20/20 vision or close to it when we were younger. There are age-related changes in the ability to detect higher pitches, which become more noticeable after we pass the age of 50. So your ability to detect certain range of sounds will be affected by age. Change in your sense of taste after the age of 60. I years ago worked in a nursing home, and we always heard from the residents there, it's too salty, it's not salty enough, it's not spicy, it's too spicy. And that's because individuals' taste buds change. We all change as we get older with that. Reduction in sensitivity to pain, touch, temperature, and changes in proprioception, your ability to kind of judge yourself in space. Reduction in balance and coordination, right? And reduction in short-term memory, attention, and retrieval. And what is sometimes called benign forgetfulness. I don't know if it's so benign, but the fact of the matter is it is not unusual for us to be unable to remember things, and it's short term. It doesn't have to do with long-term memories, and it is not the kind of memory loss that is associated with dementia. So maintaining health. What do we have to say about maintaining health? Well, one of the biggest challenges, and I'm going to say for our population of individuals with intellectual and developmental disabilities, is preventing and controlling diabetes. Type 2 diabetes, and very possibly pre-diabetes, and again I say possibly because the jury is still out about that, increases the risk of cognitive decline and dementia. Probably because the blood vessels that supply the brain are damaged with the progression of type 2 diabetes. So I'm not talking about juvenile diabetes, I'm not talking about diabetes that one may have as a child, but rather the type of diabetes that one tends to develop with onset in adulthood. Healthy eating, regular exercise, and staying within a normal weight range for your age and height all help in preventing diabetes, or if you have diabetes, it leads to better control. So you may have a tendency in your family towards diabetes, and in fact, that increases your risk factor. So if in fact you do have diabetes, you are more likely to maintain good control through exercise and control through nutrition and diet, right? Also, it is found that stress management is very important if you have, for all of us under all conditions, but if you have diabetes, because it can raise your blood sugar level if you are stressed. If blood sugar stays high, medication is needed in order to maintain good control. So it might surprise you or not to learn that many people have diabetes, do not necessarily take medication, but through diet, exercise, and management of stress, lifestyle choices tend to maintain their glucose, their blood sugar level at a reasonable level. But for many people, that is not enough. And in order to have good management, they have to take medication to control a blood sugar level. Obesity, which is a national epidemic, and is very much implicated with how we are going to proceed towards healthy brain aging and healthy aging in general. Obesity, especially concentrating excess fat in the abdomen, has been linked to increased dementia risk, okay? And obesity often goes along with other dementia risk factors such as diabetes, hypertension, and physical inactivity. I know this is something that I'm always challenged by. Controlling blood pressure. So now I'm going through some of the common health challenges that we will find, not only among ourselves, but among the people whom we support, and what we can do about that. We may not be able to stop somebody from having these conditions, but if you do have any of these conditions, hope is not, lost. There's still plenty that you can do. Again, heart health is brain health. To the extent that you keep your heart healthy, you are going the best direction you can in your overall health and your brain health. So brain health is linked to the health of blood vessels that supply the brain. High blood pressure is the most important risk factor for brain blood vessel disease. So think about that being very important. Of course, blood pressure has been linked to strokes. It has been linked to diabetes. There are a number of conditions that will affect brain health and blood pressure is something we can do something about. So diffuse white matter disease, silent strokes on MRI, brain images, and brain examination at autopsy. So here's the thing. You might be experiencing changes having to do with hypertension or blood pressure without knowing it. It's not necessarily the case that you are symptomatic. In fact, it has been called a silent killer because people have gone on not knowing that they had significantly elevated blood pressure. Yeah. So, there are things that you can do about this. For many reasons, treating high blood pressure and keeping it under control is great for the brain, okay? Right now we're talking about what's great for the brain. Now, maybe what I'll do is I'm going to shift from this barrier here and take this here. That's better. Hi. All right. So improving your blood pressure. There's definitely things that you can do. Do I have this on? Can you hear me? Nope. Yep. Okay. So there's definitely things that you can do to improve your blood pressure. High blood pressure in middle age increases the risk of cognitive decline as we age. There are ways to keep your blood pressure low, and that includes keeping your weight down, being physically active, and limiting alcohol. Sorry, alcohol also drives up blood pressure. To no more than 2 drinks per day. Okay? Finding ways to reduce stress and following a low-salt, low-fat diet. So these are all things that have been medically researched as connected to the ability to lower blood pressure. And here we're saying there are lifestyle choices that can help you modify a significant risk factor having to do with brain health. So additional risk factors, and I hate to be a party pooper about this, tobacco, again, excessive alcohol consumption. Now again, the jury is out. Actually, men and women may differ in how much alcohol you can safely consume during the week. Sorry, ladies, but it turns out we're not able to drink as much as men. Okay, sorry about that. So drinking should be limited to no more than 2 glasses a day, 12 a week, and it's probably less for females. And what's very interesting is people have an interesting notion of what a glass is. Okay. So, you have to kind of check in with what the guidelines are with regards to that. But alcohol does affect the brain. It does actually, it structurally affects how the brain functions. In fact, there is a form of dementia that you probably have heard of called Korsakoff syndrome. It used to be called wet brain. That was the result of people with lifelong history of excessive alcohol consumption. So I'm not going to say, no, don't ever have a drink. So later on, you're going to hear me tell you how having a drink helps with antioxidants. So you're going to say, well, wait a minute. You know, you say don't drink too much. On the other hand, you say it's implicated with, with healthy aging. Well, we'll try to resolve the confusion. But the main thing to know is to limit nothing in excess. I mentioned before that depression has something to do with how well we age. And depression is pretty common, right? Older adults are at risk for depression, whether you have a disability or you don't have a disability. It's treatable. It is a medical condition and should be taken seriously. And if anybody says to you, well, of course they're depressed, they're getting older, they have disabilities. No, that is not an acceptable answer. Depression is a medical condition, and it is not a normal part of aging, and it is not a normal part of aging with disabilities. And one of the problems is people think that it is a normal part of aging, and so they do not seek treatment. And it's a very treatable condition, very treatable condition. Some people are ashamed to admit they're depressed because they see it as a sign of weakness or character flaw, which it is not. It's a medical condition. Older people tend to report, and this is true for older people with disabilities as well as older people without disabilities. Very often they won't say they're sad, they will say they have a stomach ache, or they'll say that they have another symptom, or they're worried if they're anxious and depressed, they think that they're having a heart attack. Okay? So again, you always want to check out any medical issues that may be causing problems for a person, but also recognize older people have a tendency to talk about feeling not good in physical terms. Much easier to talk about a physical symptom than to talk about a psychological symptom, okay? And a lot of doctors report that the visits they get from older adults really do not have to do with medical conditions. It really has to do with being consulted as a doctor because the individual is sad, depressed, and has converted that into an expression of a physical problem. So just be alert if you have people with whom you work who in fact are reporting a lot of physical symptoms for which there does not seem to be a medical basis for their symptoms, yeah? Okay, and of course, the older you get, the more likely you are to lose your social supports. And it is a problem because your friends, your significant others, your family members may be dying, they may be moving away, the people who were with you and important to you are not there. So that thinning of social support can lead an older person with disabilities to feel rather isolated and not supported. And that puts the person at higher risk for depression. And they're less likely to independently seek help. So there are when we think about differentiating some things in terms of brain aging, I do need to bring up the 3 Ds, which many of you have heard about before, and the importance of monitoring observed decline. So I'm previewing because, in fact, we're going to come back to this when we talk about NTG-EDSD. That's my spoiler alert, okay? So there are several conditions which can become confusing to distinguish among people with intellectual and developmental disabilities. One of them I just mentioned was depression. If you're very depressed, you can look pretty out of it. You can look pretty confused. You're having problems, kind of remembering things. You're having problems making your way through your daily routine. And it's not uncommon for people to be diagnosed with a dementia who are depressed because, in fact, it looks that way, without kind of, looking into it more than you should. It can mimic dementia. Okay? In fact, we used to call depression pseudo-dementia because it gave the appearance of somebody having a dementia, even though that was not the case. They were depressed and untreated. They needed some supports. The other thing is delirium. Delirium is a medical emergency. We're going to talk about that in a minute. And they are people whom we work with who have intellectual and developmental disabilities have a higher rate of medical problems and therefore are more likely to develop delirium. I'll explain in a minute, okay? And then, of course, dementia. So those are the 3 Ds. And there are other conditions that can alter how well you think and how you function, including psychiatric illness, sensory impairment, and exposure to extreme stressors. You're really stressed out, you're overtaxed, you are not functioning as you normally would. There's a change from baseline for you. So I said delirium, it's a reversible, unlike dementia, it is reversible. Dementia is not reversible. But delirium is reversible. It's a confusional state. The person is sometimes maybe alert, sometimes not, disturbed consciousness. And it's usually traceable to a medical problem, an infection, a recent sudden change in your medical status. You've just had surgery, you've fallen and dislocated your hip. Any number of things can happen which really change your medical status, and that can lead to you being quite confused. And that is delirium because it's tied to another medical underlying condition. It is very sudden in onset. So those are 2 main differences from dementia. Sudden in onset, dementia is not sudden in onset. Okay? Reversible, dementia is not. At least the ones that we typically think about are not reversible at this point in time. So again, it's considered a medical emergency. The person who is delirious suddenly appears confused and not able to function at their baseline characteristic level. They need medical attention, post-haste, something's going on. So you can have their condition identified and they can receive the treatment that they need. And you can have dementia and delirium. Unfortunately, those are not mutually exclusive. In fact, people with Alzheimer's disease and other types of dementia are probably more likely to experience delirium than their peers who do not have dementia. Okay? And if it's not treated, what could be reversible can lead to longer-term, more permanent. This is why I'm saying it's a medical emergency, and we have to get people attention immediately. So now we go back to depression, and this is a kind of acronym which I did not come up with, not new to SIGI CAPS. These are the activities or domains that are disturbed when individuals are depressed. Sleep. People have difficulty sleeping. They either can't fall asleep, or they have a restless night's sleep, or they sleep too much, or they get up early, like 3, 4 o'clock in the morning, and can't get back to sleep even though they're tired. Interests, what we sometimes, you may have heard called anhedonia, or loss of interest in what has usually been pleasurable. So somebody loves to go to bingo, and I know a lot of people like to go to bingo, and then suddenly they couldn't be bothered to get out of bed. They used to like to go to a certain recreation activity, be the first one out the door to try to get there, and now you can't get them out of the house. Not interested, okay? And people don't usually lose interests in things. Our interests change over time, but you don't go suddenly from being very zealous about something and passionate about it to being like indifferent about whether or not you do it. Guilt, very often people who are depressed will talk about how they're responsible for things that they have no way of being responsible for, you know. And low self-esteem, feeling badly, expressing how bad a person they are, they're no good, anything that they try doesn't work out. Energy changes, loss of energy, low energy or fatigue. Concentration problems, we're going through Ziggy Caps, okay? Concentration, poor concentration, forgetfulness. Appetite changes, loss of appetite, or increased appetite. Real changes from what is baseline and characteristic for the person. Psychomotor changes, in other words, slowing down, right? Or becoming agitated. Change from baseline, that's the key. Change from baseline for a period of 2 weeks or more. And the person may begin thinking about suicide, talking about ending their life, talking about how everyone would be better off if they weren't around. They were a burden on other people. Things would be better if they weren't there. You know, that kind of thing is very much in keeping with depression. Okay, so now we're talking about, remember I said brain injury is an actually very big thing as a person gets older because of the heightened risk for falling. So you want to reduce the risk whenever possible, because falls not only lead to, hitting your head with the possibility of sustaining brain injury, lead to broken bones and other kinds of harm. And if you've broken your hip, that could lead to a real cascade in your health, right? Cascade down. So to avoid falling, practice balance and strength exercises. A lot of individuals with disabilities have gait problems and really need to do balance. We need to work on their stamina. Beware that drinking and drugs can affect your balance. This is probably not a surprise to you. And watch for uneven surfaces. Also beware that with some individuals, particularly people with Down syndrome as they age, they have altered depth perception, so they may not be able to adequately judge the distance to the ground. They may mistake where a curb, how far down a curb is. A pattern like this that is on the carpet, very lovely, but could be very confusing for somebody that has depth perception. So uneven walking surfaces where you can trip, cords should be eliminated, wear shoes or slippers with good soles, avoid going barefoot or walking in stocking feet. And I know a lot of people are used to walking barefoot. So you have to balance that out with how are they walking barefoot, okay? If you bike or ski or wear a helmet, so again, I don't know how many people are in, but biking is a big thing for a lot of the folks that I know I work with. So I mentioned before, sensory issues can very much impact upon your cognitive aging. So an example would be that you need to have good hearing and vision in order to get information about your environment. And as you age, as all of us age, our vision and hearing are susceptible to change. People with intellectual developmental disabilities, not any different. By correcting or treating those losses when possible, I know a lot of people do not like wearing hearing aids. A lot of people don't like wearing glasses if they're not used to wearing glasses. So again, you have to work with the individual and what they're comfortable with. But the fact of the matter is it will improve their functioning if they are able to have improved hearing and vision. I used to do a lot of assessments for dementia when I was in New Jersey, not that long ago. I was working and living in New Jersey before I came out to California. And one of the first people that I evaluated had significant buildup of wax in his ear, okay? And he was beginning to make statements that led other people to think either he was demented or paranoid, because he would come up with things that had nothing to do with what was going around him. He would think that people were talking about him. And in fact, he couldn't hear because he had wax buildup. So I'm not pretending that everything is that simple, but sometimes we overlook what might be obvious in terms of helping people function better, right? So they can participate in the activities stimulating for them. So it's very important to find a primary care practitioner or physician with whom the individual you're working with and whom you feel comfortable communicating with, right? It's essential for that person's health, right? You should be seeing a primary care physician on a regular basis. And for some of the people whom we support who have various chronic conditions, that may mean going to the doctor more regularly than for some others, yeah? So one of the things I've noticed is that sometimes professional as well as family caregivers are concerned about asking questions of the doctor because it's felt to be an imposition, they don't want to seem to be rude, they don't, etc. However, it's really important to know what the answer to some of your questions might be. So for instance, you need to know about medications or alternative treatments for the individual with whom you're working. You need to review and act on health checkups and health screenings. And you have to monitor existing and or new symptoms and speak up about any concerns or doubts. Very common, we have 2 nurse consultants in the regional center. I work very closely with them. They report to me. They go out to various locations, family homes and other residences. And very often people have no idea why they're on the medication that they're taking. They have no idea, okay? And I'm talking about people who would be able to have an understanding of that. This is very important, so I met with somebody the other day. He says, I take the pink pill. And I'm thinking, pink pill? You know how many pills are pink? There are a lot of pills that are pink. So you can't just go, although you want to be able to have visual recognition of the pill. It's a very good idea to have a picture of the medication people take so they can have visual recognition of it. But you also want to know why you're taking it. What is this for? That can also help with reluctance in taking medication. If you understand that what you're taking is supposed to help you in some way, very, very often not only do individuals not know, but their caregivers don't know why they're on those medications. Okay, so very important to ask questions. So not only are we talking about wellness checkups, we are talking about immunizations. There are certain age and gender-related health screenings depending on the age and gender of the individual. Again, diabetes, cholesterol, cervical and breast cancer screening for females, prostate exams for males, colorectal cancer, osteoporosis, bone densities, right? Depression and suicide risk, and cognitive screening for adults over the age of 50 who have Down syndrome, and for over the age of, well, we're probably going to make a recommendation over the age of 50 for even individuals without Down syndrome, and at the age of 35 for individuals with Down syndrome. Okay. Just seeing if you're awake. So again, some of the things that we were talking about earlier, to just summarize, that these are some of the health risks that impact wellness: tobacco usage, high blood pressure, stressful living, lack of physical activity, overweight or obesity, poor diet, home safety issues, lack of personal care, speeding. Now again, so that would be for people who ride some kind of vehicle, right? Not wearing a seatbelt or personal safety gear. So I know quite a few people who ride bikes without helmets into, you know, pretty long, and that is a concern to me. And I know people who it's difficult to get a seatbelt on them when you get them in a van or into some kind of vehicle. That is a concern, yeah. So just these are among, these have been listed as among the top health risks for people. Then the healthy habits, they should be more relaxing to listen to. Okay, so again, the answer to tobacco use is to stop or reduce tobacco use. Now, if you're somebody in your 60s or 70s and you've been smoking cigarettes since you're 12, as we have several people who I work with, that is the case, it may not be so easy for you to stop, but even if you reduce the amount that you smoke, it is likely that you get some benefit from harm reduction approach. Again, reducing blood pressure, managing stress, exercising in moderation. No one's expecting people to lift weights necessarily. You know, walking is probably the single easiest thing to do. Or if you're in a chair, you know, chair yoga. They have various stretching and other exercises that can be done if you are in a wheelchair. Maintaining healthy weight, eating balanced diet, smoke detectors, participate in cancer self-exams and age-appropriate screenings, drive within 5 miles per hour of the speed limit, wear a seatbelt in cars and helmets for bicycles and motorbikes. So again, we're talking about lifelong, what you need to engage in order to have healthy aging brain. So research has consistently found that staying physically active is one of the keys to preserving brain function. Every time I read this, I flinch because I am far from as active as I should be. Aerobic exercise seems especially beneficial, and some studies suggest that strength training can be very helpful as we age as well. And that's true for all of us, not just individuals with disabilities. So here I gave you a link, and again, you can sign up for this PowerPoint. There is a list in back when we're done that takes you to guidelines for Americans, and it is a Be Active for physical activity. And just in terms of different age range, preschool age children should be physically active throughout the day. Children and adolescents, 6 to 17, should do 60 minutes or more of moderate to vigorous physical activity. 1 hour at least 3 times a week. And adults should move more than sit throughout the day, 2.5 to 5 hours a week of moderate activity, including muscle strengthening. But even if you take a walk, that in itself, and there are things that you can carry with you if you're walking that would help in terms of muscle strengthening. When older adults cannot be active at that level of moderate intensity use aerobic activity, because in fact many people are not, because of their chronic health conditions, able to be more intensely active. And also to do muscle strengthening. And again, you can do that if you are wheelchair bound. And just engage in physical activity to the extent that you can. Moving rather than sitting is the way to go. So it's never too late to start exercising, which is good. I love to read that. I mean, I did that slide, but I love to read it. It helps you with improved strength and mobility. It improves your balance so that you can help prevent falls. It helps your mood. It decreases fatigue and lowers blood pressure, improves self-esteem. They've done cognitive tests before and after people that have done very light exercise and have shown that people, in fact, do better on cognitive exercises after they have engaged in even light activity. Okay, so it increases clarity of thinking, it can improve sleep, prevent weight gain, and improve bowel and bladder functioning. See, if we could market it, we could make a lot of money, right? People do. Sleep. Children vary in their sleep needs according to age. Adults should have 7 to 9 hours a night. How many people sleep 7 to 9 hours a night? Okay, not bad, not bad. Okay, and the rest of us have to be working on this a little bit. Okay? Sleep is actually a vital indicator of overall well-being. Your brain needs you to rest. And there is a lot that happens while you sleep, which is reparative in terms of brain cells, neurons. So, whether you know about it or not, you need to do this. And you need to have a deep sleep. You need REM activity in your sleep. It's essential throughout your lifespan. So if you're interested, there is a wonderful website called for the sleepfoundation.org that gives you what the requirements for sleep depending on your age, what are ways that you can develop sleep hygiene and promote that with people with whom you work. And I go to that site quite a bit in getting information. And of course, sleep changes occur naturally as we age, particularly after 60, because there's a shift in hormones and a melatonin level that naturally occur as we age, which may cause us to have less sleep than before. We may sleep more lightly and wake up more often during the night. And it cannot be taken lightly. Lack of sleep can affect your immune system, it can increase your confusion, it can affect your mood, and may lead to falls. Okay. Develop a more consistent sleep routine, go to bed at the same time every night, and wake up the same time every morning. Fall asleep in the same position. Have a cup of warm milk or herbal tea before bedtime. Try a warm soak in a tub and address snoring issues because they often will signal medical problems. Snoring that is serious may mean that breathing is obstructed, and it could be an indicator of sleep apnea. For some individuals whom we work with, particularly those with Down syndrome, they are prone to sleep apnea because of the structure of their face, okay? generally speaking, more at risk for that. Okay. And the CPAP, a machine may change the client's life for the better. Try to avoid late night stimulating activity. If you think that she's moving her leg, it's because she is. Okay? This is not a hallucination that you're having. Okay? Try avoiding especially spicy foods late at night, watching TV or lively debates, anything that would cause you to be aroused rather than to wind down. So all of us need a way to kind of wind down before getting to bed. And then I would say skip afternoon naps. I was talking to one of the clients we have at the regional center who told me he takes 2.5-hour naps, and then he was wondering why he had trouble going to sleep at night. I said, I think there may be a connection here between you taking power naps, 20 minutes, that's great for power naps during the day, but try not to do longer than that because it can really throw off your sleep cycle. If you are on the autism spectrum, you may naturally have, because of that condition, circadian rhythm problems. Many individuals with autism spectrum disorder are thrown off, cannot get to bed until really late, wake up really late, and seem to have a hard time kind of going with the usual circadian rhythm. So another thing to consider if we're thinking about healthy brain aging is blue zones. How many of you know about blue zones? Okay, good. There are countries that we have studied because people tend to regularly live into their 90s or older in good health. And so there's some lessons that we have. So there are 7 places. I don't know if I remember all of them. I know Okinawa is one of them. I know there's a place in Greece. There's a place in Sardinia. Loma Linda in California, for whatever reason, is another place. There's a place in Russia. There are a couple of other places that, that I can't kind of quite, but if you want to Google or Bing blue zones, they will give you the listing of those countries or areas in the world where people seem to be living longer. So what have we learned from that? You move naturally, and you walking, gardening. You have a purpose for waking up each day. You have routines to deal with stress. You stop eating when you're 80% full. This one I haven't gotten yet. And eat smallest meal at the end of the day. Your diet includes a great deal of beans, fava, black, soy, and lentil. You drink wine moderately, right? You belong to a faith-based community. You put families first, and you belong to social circles that support healthy behaviors. These were things that were in common across all 7 very culturally different parts of the world where people were living longer. So again, you can follow a 95-5 rule. Eat mostly plants. 95% plants to 5%, animal protein. Eat small portions of meat, moderate fish because of pesticides. Avoid cow's milk. Here I was brought up to believe you drink milk on a regular basis, right? Eat a cup of beans daily. Limit your sugar. Use honey instead to sweeten. Eat a handful of nuts daily, right? Eat only 100% whole grain breads. Eat whole foods or ones with fewer than 5 ingredients. And drink mostly water as your beverage. So that's what we learned about the dietary habits of people who live in the blue zones. And again, very different culturally, very different places where they had these commonalities. So some more diets: the Mediterranean intervention for neurodegenerative delay, which is sometimes called the DASH diet. Dark chocolate, I particularly like that one. with at least 85% cocoa, turmeric, kale, sweet potatoes, berries of all kind, garbanzo beans, walnuts, fish with omega-3 fatty acids like mackerel, lake trout, herring, wild salmon. I would be talking to you about this before lunch, right? So we got you going, huh? Red wine, remember I told you not to drink too much, but here it says, you know, red wine seems to be good. It's an antioxidant. And green tea, which also has antioxidant properties. Overall recommendations for healthy diet. And the reason I'm dwelling on this is because, in fact, this is what we are able to modify, make different choices, eat more fruit and vegetables, whole grains, legumes, limit sodium, sugar, and saturated fats, limit fast foods, cook your own meals, and learn to read ingredients, labels on cans, and packaging. So I'm gonna, if you want the PowerPoint, I really recommend you sign up for it. There is a sign in, and you can look at these. I really dwelled a bit on this. You could tell I was probably hungry when I was working on my PowerPoint, that I was so kind of pre-focused here. But the fact is I want to make sure to get to some other things so I'm going to switch to this. Mental activity and lifelong learning. Now, for people whom we work with who may not be academically oriented, another way to engage in lifelong learning is learning how to do new things, learning how to cook new recipes, learning how to sew new things, learning new activities. It doesn't have to be learning in an academic or classroom level. Social connection. Sounds like we have some social connection going on in the hallway, yeah, with some music and stuff. So staying active, interpersonal exchange, very important. Social connection and making sure that one is not isolated and without support. Enormously important in terms of healthy brain aging. Learning ways of handling stress. So when we're stressed out, hormones, we secrete hormones that have a strong effect on the brain. And it's very challenging for us to kind of recover from that. The older we get, it's harder to offset that. So again, we learn ways to cope with stress so we don't become anxious and depressed. That's another way to help with healthy aging cognitively. So I have a little bit about developing healthy habits. We all have the opportunity of making different life choices. One of the ways to do this is to make a conscious effort, study our patterns, know what we want to do differently. For instance, I know I have to increase the level of physical activity. I am pretty much a couch potato. So in fact, I know that this is something I have to consciously work on. This is not going to come naturally to me. So I'm thinking about ways that I can, without extreme effort or expense, make some modifications in my daily routine, walk a little bit more, park my car a little bit further from where I have to be, get out hiking on the weekends, doing various things that are enjoyable and I'm likely to keep up with. But I have to recognize it takes at least 6 weeks to change a habit. So you need to be at something at least for 6 weeks. This is true of the people that you work with. It's true for you. It's true for all of us, that it takes about 6 weeks for us to do that. And have someone to whom you're accountable for a change in habit. Very good to do it with a buddy, a significant other, somebody you say, this is what I'm working on, will you work on this with me? Okay, we make a plan, we make our healthy choices easy choices, not anything that we know we're not going to be able to follow through on. Get friends and loved ones involved and plan for obstacles. And that is, any new habit there are going to be reasons why we're not following through. Oh, I have a work deadline. Oh, my family's coming to visit. I have to be getting the house pulled together. Oh, my child needs this, or this person needs that from me, that may pull us away from our intent. So the fact of the matter is, what we want to do is we want to be able to plan for this and come up with the strategies to overcome the barriers we may have. So where to start to positively impact your brain health? Start with one small step in the right direction, something that's doable. Schedule a health screening or physical exam, and I'm talking about for you as well as for the people whom you support. Review your medicines and the medicines of the people that you are working with their health care provider on a regular basis. Add one daily serving of vegetable to your diet if the person does not eat vegetables. Start a food activity or health journal. Keep a diary to see what you're actually doing. And find a community center and what's on the activity schedule. What is free to go to? What activity might we be able to add? And we talked about the 3 Ds, so I'm going to skip that. So what we're really concerned about and why we came up with a National Task Group Early Detection Screen for Dementia is that these were memory problems that we want to track that interfere with the person's functioning and daily activity. Of course, people who may develop dementia have problems in orientation to time, place, or person. They slow down in their movement, thinking, and processing information. There may be a coarsening of their social behavior, so they act in ways that are inappropriate, which they never did before. Okay, it's a change for them. They may be increasingly impulsive, difficult for them to learn new things. Like they have a new staff person, they can't seem to get the name of that person. They're always calling that person by a previous staff member's name. Yeah. A change in an ability to communicate, because dementia actually can impoverish your ability to communicate. Problem pursuing well-learned routines and activities. So if you used to work, you may not be able to do your work anymore. You may not be able to be productive in the way that you had been. And confusion in familiar places that lead you to get lost and lead you to feel challenged even within familiar environments. Okay, so we want to look at, and dementia, or what is termed neurocognitive disorders, affect more than memory. People get focused, hyper-focused on memory, but actually dementia is more than just memory. It's changes in cognitive skills like attention, problem solving, perception, and language. It's a change in social skills, such as understanding behavior, your own and others, and your emotional, and I have an and sticking out there. But it's your social skills. Behavioral skills such as self-control appropriate to your setting and situation, and your adaptive skills, your ability to dress yourself, toilet yourself, feed yourself, all the basic activities of daily living, which are part and parcel of being an independent adult. And dementia will affect all of those skill sets. Individuals with Down syndrome we know are at particular risk, although there's no reason to believe people without Down syndrome are not susceptible to getting a neurocognitive disorder. We know less about people who do not have Down syndrome and what the likelihood of their ability of developing dementia is. But we do know that it's unlikely that they develop it as early as individuals with Down syndrome. So actually your brain changes 1 to 2 decades before it becomes obvious in your day-to-day activity. So your brain is changing even though it may not be apparent to anybody. So the structural change of your brain. So that's why it is so important for us to have a way of doing an early identification in individuals' functional abilities. So we begin to observe, you begin to observe, professional caregivers, family members, begin to observe changes in the day-to-day functioning of the people whom you know so well, right? And you are in the best position to provide that information to healthcare providers, who then can, with the team, make decisions about next steps. And that's where we come up with the National Task Group Early Detection Screen for Dementia, the NTG-EDSD. What it is meant to do is to capture observations of change that may indicate the person is declining cognitively and adaptively. So what is the benefit of having an early identification? Well, one of the benefits is it can lead us to act more quickly in the direction of providing supports, in targeting interventions and care, and it gives us an opportunity to plan for things rather than being caught by surprise when the person already is well advanced into a situation. And early diagnosis can help ease the anxiety that may accompany unexplainable changes in behavior. Sometimes people change in their behavior and people wonder, are they doing it purposely? Is this something that is under the individual's control, or does it have to do with their aging brain changes? So by capturing your observations of change, we can have that dialogue with healthcare providers. And it is also important for quality of life for a person with dementia and their family, so that we can do the most active planning possible. Of course, having an intellectual and developmental disability may complicate the recognition of a neurocognitive disorder. Okay? We do not have tests that have really been designed to identify. In the general population, we have the dementia rating scale and some of the other batteries that are used for the generic geriatric population. But actually, we do not have a tool that we've agreed upon that would identify neurocognitive disorder among people with intellectual and developmental disabilities. And that is because all the other tests for the generic population are based on the assumption of average IQ. And it's also based on the assumption of a certain amount of education. So that may not be applicable, may be applicable to some of the individuals whom we support, but it may not be applicable to many others whom we support. Things to know about dementia. Dementia itself is not a diagnosis. We talk about dementia because that's how people normally think of it. It's neurocognitive disorders, right? And it is a brain disease. Dementia is an umbrella term for changes. Alzheimer's disease is the most common form of dementia. The average age of onset for people with Down syndrome, who do have, not everybody with Down syndrome progresses to dementia, but the average age is 52. And it is older for people with an intellectual disability who do not have Down syndrome, okay? Progressive decline can last from 1 to 7 years for persons with Down syndrome. As the disease progresses, so do the care needs of the individual. That's why it is so important for teams to capture their observations of change, because what you do in planning supports and programming has everything to do with your observations of change for the person. Okay, person is going to have a problem with memory, self-care, communication, ambulation, any number of things. So here is that idea of an umbrella term. Under that umbrella term is Alzheimer's disease is the most common, certainly the most common that affects individuals with Down syndrome. Vascular dementia, Many individuals with Down syndrome have both vascular dementia and Alzheimer's disease. We have frontotemporal dementia, Parkinson's disease dementia. So there are many forms of dementia under that general category, but these are all forms of neurocognitive disorder. So here you have a picture, of two brains. The one on the right is somebody that has Alzheimer's disease. The one on the left is a healthy brain. What do you notice about the brain on the right? Anybody? Smaller, yeah. And then you have what are called, let's see if I can do that. These are called sulci. Look how deep they are, how wide the spaces are here, and how tightly wrapped around they are here. And this has everything to do with the lack of connectivity between brain cells when a person has Alzheimer's type dementia. Okay, warning signs of dementia. It's unexpected memory problems, getting lost or misdirected in a familiar setting, problems with gait or walking because it's a neurological condition and can very well affect ambulation. The onset of new seizures is something that you may very well see in somebody, or somebody who has not had seizures since childhood, they may again have seizures. And that's because anything that affects the brain and causes lesions or changes in the brain can lead to seizure activity. Confusion in familiar situations, changes in personality. I used to hear all the time, not that my loved one is confused or has memory problems. I used to hear, Joe is just not Joe anymore. He used to be the sweetest and most gentle guy, and now every morning we get into a boxing match over taking a shower or putting on clothes or doing hygiene. Okay, Joe just isn't Joe anymore. So very often, because people have had memory problems to begin with, that becomes less obvious than personality changes or changes in style, right? And difficulty maintaining social connections with families and friends because of changes in communication ability. You'll find reduced work performance, difficulties with recent memory and new learning. I mentioned not being able to remember the name of staff that comes on that are new. Emotional ability, heightened irritability, or apathy, and again, social skills just kind of drop out. When you observe a change in thinking, mood, or behavior that's different and it's lasted for a period of 2 weeks, you should make an appointment with a doctor. That is the first step, the primary care physician, okay? And advocate for an assessment if the individual demonstrates behavior change, at work or in residence or family setting. People don't randomly change the behavior that they've engaged in. And that's not true for us, not true for anybody. So the rationale for the development of the NTG-EDSD was we wanted to equip family and professional caregivers with a tool to capture information about changes in cognition and functioning. We heard from people, they're not getting to the doctor, and the doctor doesn't see anything, or the doctor says, well, of course they have intellectual or developmental disability. Of course they're going to have these problems. When family and professional caregivers said, no, this is different. We're observing something different. So it is an administrative tool to capture those changes that you observe. And then it will help to become better observers of any change, as well as what to report to the healthcare provider, okay? It can be used as part of the annual wellness visit. Remember, I am putting down, and you can see, administrative tool. It is not a diagnostic tool. You would not have somebody diagnosed with Alzheimer's or another form of dementia on the basis of this tool. This is a way for you to have a conversation with a healthcare practitioner. So that's what that is. It's based on an earlier tool that was developed by Shamitra Deb, a British psychiatrist, in 2007. And we decided to do a couple of changes to it. We also used something that was developed by the Philadelphia Coordinated Health Care Group in 2010. Now, I am making the recommendation, it may say something different on the form, that for individuals with Down syndrome, start baselining at age 35. For people who do not have Down syndrome but have another form of intellectual developmental disability, after the age of 50 is fine. It was piloted in 2012. It is now used internationally. If you go on this website, you will see the American Academy of Developmental Medicine and Dentistry on their NTG page. It's probably in 8 or 10 different languages. Scotland uses this routinely with individuals who are associated with Down syndrome, their project. So again, the EDSD is not for diagnosis, it's administrative. It's not a clinical rating tool. The diagnosis of having a neurocognitive disorder, Alzheimer's, cerebral vascular, any of the forms of dementia that we've briefly referenced, is a more complicated process. You have to do lab work, you have to have the person tested, observed, etc. And so this is just a first step in getting information down when you observe change. The person already has a neurocognitive disorder, you use this as a way to baseline where they are. It's not necessary to continue using once you've established the person has a neurocognitive disorder. The NTG is coming out with another tool that will be useful to healthcare practitioners once somebody is diagnosed with dementia. So what's the role of family and professional caregivers? You are raters on the NTG-EDSD. You do not need the person involved with you. This is not anything where they're asked to do anything. It's a rating form that caregivers fill out. If you're a staff member, you need to know the person for at least 6 months so that you have some and the reason we say 6 months, I don't know what the experience is here in Hawaii, in California and other places, it is rare to have people who are working in the field with a person for longer than 6 months. You complete it, you gather your medical and other chart materials to fill out some of the questions. And it's a good idea if the person attends a day program or is in multiple settings, have the staff fill out their own form of the NTG-EDSD so you can compare it at home, at program, wherever they may be the different settings involved, because there may be different pieces of information depending on the setting. You utilize the findings. Individuals who've displayed new symptoms in at least 2 domains on the EDSD should warrant some concern. If the person has gotten worse and symptoms already noted, that's a concern. If delirium, has delirium been ruled out? Has depression been ruled out? What is the healthcare provider suggesting with regard to medication, monitoring, and non-pharmacological intervention? So these are among the domains in which you're asked to give some indication on the NTG-EDSD. If you are interested in getting more information about the rating tool itself, which I hope you are, then Wednesday morning we have a workshop just dedicated to that, where I will actually be going through the form with people who attend, and that will be at the ARC. And there's information about that for the Wednesday morning session. It's free. These are the domains: behavior, personality, memory, activities of daily living, and sleep. We establish any departure from baseline based on the observation of people who are familiar with the individual. And sometimes people self-report. I've had people who have filled out with their caregiver, family or professional, and they report, I am no longer able to do this, or I used to be able to do that and I can't do it anymore. I mean, not usually the case, but I have had instances. We look for patterns. What are the areas of change noted? Is something being done to address the issue? Bring the team in and brainstorm options, develop an action plan, share with everybody, and then evaluate the effectiveness of the plan. So here is the idea of sharing. It is very important. You know, you always get somebody who says on shift, I know how to handle this person. Okay, well, share that information. If you know how to support the individual effectively, then share it with other members of the interdisciplinary team. And the EDSD can be helpful in generating that conversation. Okay, and so what are the types of decisions that may follow from the use of this tool? Well, we might decide the person needs more support, and that may need a modification of residence or programming, or a change in residence, or a change in the type of support, or developing a different daily routine, or identify items and activities that will be more stimulating that the person can still do. So there are any number of areas where we might be able to intervene. We want to promote time-sensitive intervention and support, and that is very important way that by looking at what we have observed about change, we can use that information more effectively in program planning and staff deployment. We want to also share that information with a person's physician about daily functioning, and advance the conversation, because it may lead to the person getting an assessment or diagnosis. And I found sometimes with the EDSD, we find the problem is not dementia. It becomes a way of ruling out that that is the problem. There's some other problem that winds up being the cause of observed change. And we want to get the most out of visits with our health care provider. Okay, and again, we also, in addition to wanting to be effective, we want to pay attention to quality of life for people as they age in place, hopefully. All right, we could rule out other factors. We may wind up hearing their recommendations for further testing and evaluation. Although it's not a diagnostic tool, it may result in a referral for further, which will wind up leading to a diagnosis of that. So we are here, okay? And again, this all came about through the National Plan to Address Alzheimer's Disease. Every state has its version of the national plan. Okay, Hawaii has its version of the national plan with the 5 goals of preventing and effectively treating Alzheimer's disease by 2025, optimizing care quality and efficiency, expanding supports for people with Alzheimer's disease and their families, enhancing public awareness and engagement, and tracking progress and driving improvement. And this NTG-EDSD is part of how we are looking to advance that for people with intellectual and developmental disabilities. So a model system would educate the public about brain health, identify people with possible dementia. The NTG-EDSD can help with that. Ensure that program eligibility and resource allocation include people with cognitive disabilities. Okay, ensure staff communicate effectively with people with dementia and their caregivers. Okay, educate workers. Educating the workforce, which is what we're doing right now, is a very important part of a system that will improve brain aging, for all of us, and particularly the individuals whom we support. Implement quality assurance systems that measure effectiveness and encourage development of dementia-friendly communities. So that's what a model system would be. So I believe firmly to educate is to empower. These are some of the many websites that you might find informative. NIH is a treasure trove, the National Institute of Health, about Alzheimer's disease. We have also the AADMD, the American Academy of Developmental Medicine and Dentistry, and the CDC, one of many. So I want to thank you for attending the presentation and ask you for your questions or comments. We have a few remaining minutes before I have to spring you for lunch.